Alrighty, let's keep trucking. There's some specific disorders that this endocrine chapter talks about. I'm going to skip some of these, like hypopituitarism. Going to skip that one. Diabetes insipidus is a very confusing diagnosis that you will see from time to time, depending on where you work. There's another one that we'll talk about, which is a syndrome of inappropriate anti-diuretic hormone, SIADH. And if you can sort the difference between the DI and the SIADH, it's very confusing, very confusing. But if you can figure the difference out, it would it'll help you on the exam. But I was just thinking of back to 2 summers ago when I took 6 certification exams in 6 weeks. Of all of those exams, so each exam was 170 questions or so. There was one question about DI and one question about SIADH. And so as far as bang for your buck, you won't get a good return on your investment for understanding these as far as test taking goes. But they are super interesting. They're very interesting diseases. And what I like about DI is the 2 places you will see this in the hospital are my 2 favorite places to be. The ICU, critically ill ICU patients will get diabetes insipidus. And the second most common place is the locked mental health unit. The psych patients get DI. They get a variant of diabetes insipidus. So we see this patient probably, I would say, like once a month. Once a month, I'll run across a DI, either in the ICU or on the psych unit. The confusing thing about diabetes insipidus is the word diabetes. It actually has nothing to do with blood sugar. It has nothing to do with type 1 diabetes or type 2 diabetes. If we think back a couple of 100 years to when they were naming diabetes, what diagnostic tests did they have? Well, the only real way we could diagnose the diabetes that involves your sugar or the diabetes insipidus is by noticing that our patients were peeing a ton of dilute urine. So our patient who has diabetic ketoacidosis because their blood sugar is sky high, they're peeing a ton of urine out. And so you might have seen diabetes insipidus if you work as a CNA and you had to dump somebody's Foley bag. Have you ever dumped a Foley bag that looked like it was going to explode? And most of those Foleys, I'm trying to think even how much a bag holds now. Maybe 12, maybe 2 liters, which would be like 2,000 cc's. And you dump 2,000 out, that means you have to take the little graduated cylinder and fill it to the top and then very carefully walk to the bathroom. Try not to spill it. And then you go back and you fill it back up again. And you do that a couple, 2 or 3 times to dump that Foley bag. And then maybe this was right before breakfast that you did this. And then at lunchtime, you notice you got to do it all over again. And they've already filled up another 2,000 milliliters, 2 liters. That's classic DI. diabetes insipidus. There are tons of large amounts of dilute urine. The problem is this person shouldn't be peeing so much. They should not be peeing so much. And what happens is they're actually getting dehydrated. They're getting dehydrated at the cellular level, super dehydrated. And so if we check their sodium, if we draw their blood, check their sodium level, their sodium is sky high. And the reason for that is they peed out the plasma in their bloodstream, which has made their sodium become super concentrated in the blood vessels. So DI has a sky high sodium level. There's two different causes. It could be your brain, which is called central DI. Could be your brain that's the problem, or it could be your kidneys that is the problem. Either the brain or the kidneys. By brain, I'm talking the posterior pituitary gland. But we see it in head trauma, in our head patients, we call them. We see it in brain cancer patients. Different problems with people's brains and heads. It could be skull fractures, could be brain cancer. Those are probably the most common central DI. And then nephrogenic just means that the kidneys themselves are having problems. And so you're just peeing out tons of dilute urine. You're not really getting rid of the waste products with the pee. You're just peeing straight water. So the sodium climbs and climbs. One of the weird psych diagnoses that looks exactly like this is called Psychogenic Polydipsia. And that is a patient who is peeing tons and tons, but they're also drinking tons of water. So it's not quite DI, they're doing it to themselves. Psychogenic polydipsia. Signs and symptoms, frequent urination, and then since they're completely dehydrated, they're just dying of thirst. They're super thirsty. So the blood tests will show high sodium. High sodium. Also high osmolarity, that fancy word means their blood is very concentrated. It's very concentrated. Diabetes insipidus is not the same as diabetes mellitus. There's no blood sugar issues. No blood sugar issues. We treat that by giving ADH. We usually give that ADH as a nasal spray. So you might have seen that given as a nasal spray called vasopressin. Hyperpituitarism, I can't say that we see that very much. So I skipped to SIADH. This is the exact opposite of DI. Diabetes insipidus, sky high sodium. SIADH, super low sodium. And so if you don't know anything else about those two, I would say if you could memorize sky high sodium is DI, super low SIADH. Again, with SIADH, brain injury or neurosurgery, very common cause of SIADH. Other very common cause, lung cancer. That's what that phrase paraneoplastic means, is they've got a tumor in their lung that's spitting out ADH. And you usually know this patient because they come in and they tell you, I smoke 2 packs per day. We had this patient on Monday of this week and Monday of last week. We take care of SI-ADH actually quite a bit. Anytime a patient comes in with super low sodium, we have to assume that this is the cause. And it usually is the cause. When your sodium is really low, that actually means that your blood plasma is waterlogged. Your sodium drops because you have too much water. Too much water. It's diluted. Your plasma is diluted. Low sodium. So we treat these guys with a fluid restriction and a very slow correction of their low sodium. If we correct it too fast, they will develop cerebral edema. Their brain will swell up. We have to very carefully correct that low sodium. The textbook definition of how low is too low, when your sodium gets to be 118. You're down about 118, you will have full-blown tonic-clonic seizures. Tonic-clonic seizures when your sodium gets too low. And again, that's called SI-ADH. I just think it sounds good. I like the sound of that. SI-ADH, syndrome of inappropriate anti-diuretic hormone. In reality, I would say nobody understands it. Nobody understands it. And so if a doctor has a patient with super low sodium, they always write the order for consult nephrology. Consult nephrology, because the kidney doctors do understand it, but nobody else does. None of the rest of us understand it. The thyroid disorders are very, very common. Very common. You'll take care of tons of patients that have hypothyroidism. Hypothyroid, which means low thyroid. Your T3 and T4 are the thyroid hormones that are doing the work. They're doing the work, and the work that they're doing is metabolism. Metabolism. And so if your thyroid levels get low, your T3 and T4 get low, you will look like a slowed down metabolism. Slow metabolism looks like no energy, fatigue, weight gain. You start gaining weight and you feel depressed. Low thyroid, hypothyroidism, and major depressive disorder look exactly the same. They look exactly the same. If you have somebody who suddenly is very depressed, the very first labs to check are their thyroid disorders. And probably about 10 years ago, in the state of Nebraska, we added TSH, T3, and T4 as lab tests. We added those to the routine emergency protective custody labs. If you are suicidal and the police find you on top of a building downtown, they will place you under emergency protective custody and take you to the Lancaster Crisis Center under an EPC. And then the very first thing that they will do is check your TSH, T3, and T4. Because major depression and hypothyroidism look exactly the same. A goiter is when your thyroid starts swelling. And you may have seen pictures. I don't know if they have a picture in the book of a goiter. That's an enlargement of the thyroid. May or may not present with signs and symptoms, but probably the most common cause worldwide is malnutrition or lack of iodine in the diet, low iodine levels. And so if you have a container of salt at home, take a look and see if it's iodinized table salt, because that's a vital nutrient. And our government 100 years ago recognized that people weren't getting enough iodine, so they made the salt companies add it to their salt. One of the big fads right now with eating and cooking is people are using salt like pink Himalayan sea salt. And you guys cook with that? The different sea salts, some of them are really tasty and they add a great flavor to your food. And we cook with a lot of sea salt. But the problem with that potentially is you're not getting enough iodine. The standard American diet is super high in salt. So if you eat fast food ever, you're getting plenty of iodine, so don't worry about it. But if you're just eating all natural, vegan at home with pink Himalayan sea salt, there's a chance you might not be getting enough iodine in your diet. That's the government said we got to add that to our table salt. But worldwide, we see goiters all the time because in developing countries, people are not getting enough iodine. I'll tell you a story about this. When I went back to school to work on my BSN, I had been an associate degree RN for a couple years. And then I went back for my BSN and I took pathophysiology for the first time. When I went to ADN school, we didn't require patho to become an RN. Anyway, I took pathophys and I had to build my first patho map. And the patient that I picked was a patient I had taken care of in the ICU. And what had happened, she was a refugee from Guatemala. And you know the difference between an immigrant and a refugee is an immigrant wants to be here. A refugee is not safe where they are at, so they have fled to another country. So she was a refugee, and she had fled from Guatemala because of an abusive husband. Her husband used to beat her up terribly, and she packed her bags and snuck out and ran away from home, landed in Nebraska. Well, her angry husband was furious, and so he hired a shaman or witch doctor to put a curse on her. And the curse was that she would die before the new year. That's what the magical spell said. You will be dead before New Year's Day. Well, she believed in this enough that her and her friend stayed home on New Year's Eve and had all the doors locked. And they were ringing in the new year by themselves. The 911 call was placed at 11:59 on New Year's Eve. And the dispatcher said, CPR in progress. Ambulance went to the scene, went to the apartment building. They shocked her and got her back. And then she came to me in the ICU. She was still critically ill, and we didn't know what was going on. Had no idea why a young 30-year-old female just dropped dead. One of the internal med doctors noticed that she had a goiter. And it wasn't real obvious, and you can't necessarily tell unless you're specifically looking for an enlarged thyroid. My brother was in nurse practitioner school, and at the time his wife was a YouTube sensation. She's a musician, and she was a famous YouTube musician person. And my brother noticed for her, he watched a YouTube video from a year prior, and he noticed that over the course of about a year's time, she developed a goiter, which was noticeable. And that was the first symptom that she had Hashimoto's. She wasn't having any symptoms yet. She was developing a goiter. With that goiter, I'm going to skip the hypothyroidism stuff. Our patient from Guatemala had hyperthyroidism. She was kicking out way too much T3 and T4. And it got so bad that she developed, let's see if I have I don't honestly know. Oh, here it is. Yeah, she developed a cardiac dysrhythmia, went into VFib, basically, and the doctor called it a thyroid storm, thyrotoxic crisis. So this is a very confusing patient, though. If you look at this slide, these guys always come in with a high fever. And if you think about the thyroid hormones are metabolism. So your metabolism is in overdrive. And that's actually where that high fever comes from. But that always, as nurses, that makes us think infection, right? Oh, this patient's septic, has an infection. But she had tachycardia, high heart rate, which was so fast that it ended up fibrillating, going into what we call VFib. That's why the paramedics had to shock her. And it is a true medical emergency, a thyroid storm. And the doctor picked up on that because of her goiter. I'm going to go back to that goiter slide. It was a super cool patient to take care of because the family hired a shaman to come into the ICU, and they did rituals that included burning incense around the bed and doing different incantations and things to reverse the spell. And we actually had to get together with the maintenance people at the hospital to shut the fire alarms off in the ICU, because here they are burning stuff at the bedside. And we had to shut off the sprinkler system and everything. And it was just a super cool patient to take care of for that reason. But that's a goiter. It can lead to hyperthyroidism. The other one, the most common one that you'll see is hypothyroidism. The patients with the high thyroid, the hyper, like I just talked about, a lot of times after we take out part of the thyroid, they develop then hypothyroid. So it can be very confusing when you're looking at past medical history. You'll see that they have hyper listed, and then you see that they have hypo listed. Often it's because when we treat the hyper, we go a little bit too far, sometimes on accident, sometimes on purpose, and now they are hypothyroid. Probably the most common hypothyroid, though, is Hashimoto's. Hashimoto's just simply an autoimmune, your own immune system attacks your thyroid. And with Hashimoto's, most commonly middle-aged women. And so the postpartum period is especially high incidence. I did bring up a website, the CDC. Can't see, specifically talks about a variant of thyroid disease called thyroid cancer. So you can get cancer of the thyroid, and this is out in the cancer chapter of the book. But I just wanted to mention this because thyroid cancer is getting to become a problem in the United States because our scanning techniques are getting much better. Like our ultrasounds and our CAT scans are much better. Just in the last 5 or 8 years, if we scan somebody's thyroid now, today, we will always identify a potentially cancerous nodule. And so one of these pages here specifically talks about what types of cancer we should screen for. And if you scroll down this CDC recommendation, they recommend breast cancer screening, cervical cancer screening, that's your pap smear, colon cancer screening. Gotta get that colonoscopy. And my doctor told me I'm of the age now where I gotta get a colonoscopy. I told him I'd rather die of cancer. So we'll see what happens. I don't know. I'm just terrified of surgical type procedures. I don't know. Lung cancer, gotta get a screening for that, especially if you're a smoker or former smoker. But here at the very bottom of their recommendations, screening for ovarian, pancreatic, prostate, testicular, and thyroid cancers has not been shown to reduce deaths from those cancers. They found insufficient evidence to recommend screening for those, including bladder and oral, if somebody doesn't have symptoms. And skin cancer, just a visual skin exam. The reason these recommendations is kind of weird. They're saying stop, the official statement of the CDC, stop screening for thyroid cancer. Just stop it. They came out that just a couple years ago. And the reason they say is we are yanking, and by yanking I mean surgically removing way too many thyroids now, because our scanning techniques are so much better. Every single thyroid we scan meets the criteria for having cancer and it needs to get removed. The problem is you remove that thyroid and now you have a permanent state of hypothyroidism. And that patient will always have to be on Synthroid. Synthroid is that thyroid pill that we give for hypothyroidism. And the certain cancers like prostate cancer, and I believe thyroid also, is there's such slow growing cancers that prostate cancer, you will usually die of a different cause way before you die of your prostate cancer if you're in your late 70s, 80s. Signs and symptoms of low thyroid: hypothyroidism, cold intolerance, weight gain, fatigue, lethargy, poor attention span, brittle nails, hair loss, puffy face, constipation, muscle cramps. Hypothyroid, very common. The confusing thing about blood work is usually these patients will have a high TSH. And so as nurses, we always think, oh, if it's high, it's hyper, right? But that's incorrect. High TSH is called hypo because what we actually care about is the T3 and T4. Super confusing, but it goes back to that negative feedback loop. If you have low bloodstream levels of T3 and T4, your thyroid thinks it needs to secrete more TSH, or your pituitary gland, I should say. The negative feedback loop. Hypo means low T3 and T4, and your pituitary thinks I need to fix this problem. So super high TSH. And that's usually the only lab that they order initially, is a TSH. And if it's at high, you have hypothyroidism. Does that make sense? That's confusing, isn't it? That's called primary hypothyroidism. It says that on a slide, a couple slides down. High TSH, low T3 and T4. There is a different type where you could have low everything. That's called secondary. That's actually a problem with your pituitary gland, not your thyroid gland. It is recommended that we check those levels in women at age 35 and every 5 years after, because 35-year-old women are the ones that get hypothyroidism. We replace the thyroid with levothyroxine. The trade name of that is Synthroid. You could get such a low thyroid level that you develop what's called a myxedema coma. These dudes tend to die from this. This is a critical patient, critically ill, myxedema coma. And then hyperthyroidism, I kind of talked about the patient who coded at midnight on New Year's Eve, had elevated T3 and T4, and she technically had Graves' disease. Graves' disease, they tend to develop a goiter, a swollen thyroid, their neck. You can see it's pretty impressive. Again, that's autoimmune, a darn immune system. If a low thyroid looks like depression, high thyroid looks like anxiety. High thyroid looks like anxiety. And generalized anxiety disorder and major depressive disorder are the number 1 and number 2 most diagnosed psych disorders worldwide. And Graves' disease and anxiety look exactly the same. The other thing these dudes tend to do is bop into Afib. That's a heart rhythm. Afib. So if somebody is a new Afibber, first lab we got to check is that thyroid. Check that TSH. When the Graves is pretty bad, they get a very characteristic bulging eyeball look to them, a bulging eyeball look. My track coach in high school, I remember, had the bulging eyeballs, and I always thought it was because he was mad at me because I wasn't running fast enough. He actually had Graves' disease. Here's a comparison of low thyroid versus high thyroid. Hypo looks like depression. Hyper looks like anxiety. So to treat high thyroid, we will try PTU. PTU is an anti-thyroid med. Might give them some radioactive iodine treatment. Might remove the thyroid or part of it. If we remove that thyroid, they have to be on Synthroid the rest of their life. And it's hard to regulate those thyroid levels. And in fact, we don't even have good research on what is a normal TSH and T3 and T4. We are not convinced that we know what normal is. And what we see on the mental health units is treatment-resistant depression, which means patients were given them antidepressant medication and they're still sad, low energy. They feel like life's not worth living. We've been adding Synthroid to their med list, even if they have a normal thyroid level. And a lot of times that magically fixes people. Can magically fix treatment-resistant depression, because what it really is, hypothyroidism. Talked about Thyroid Storm, fascinating. I'm trying to think how many times I've seen this, though. Not a lot, maybe twice in the last 20 years. So it's not something you see a lot of. In developing countries, though, they do see more of it. This talks about the thyroid nodules. And one of the problems is everybody has one. Everybody has a little nodule in their thyroid. Sitting on the back of your thyroid is the parathyroid gland, and they secrete parathyroid hormone, which is released when blood calcium is low. So what you need to know about the parathyroid is calcium levels. Calcium levels. And in reality, the only time we deal with this patient, like the hypoparathyroidism, the only time we really deal with this patient is after somebody has their thyroid removed. It's very difficult for the surgeon to pull your thyroid out and not accidentally pull your parathyroid as well. There's two little tiny nodules, very difficult to even see when they're making that incision. The surgery is a lot better now, but still, I would say the few times you will see a true hypocalcemia is inadvertent damage. I guess it's right there on the PowerPoint slide. Inadvertent damage with thyroid surgery. So you get this patient post-op back to the floor. They got a bandage on their neck. They've just had their thyroid gland removed. The surgeon accidentally took their parathyroid. And they start having these crazy symptoms of low calcium. Low calcium. One of the symptoms, like Trousseau's sign, pretty fascinating. And you notice it when you pump up their blood pressure cuff. And they spasm really easily. Muscle cramps and tetany, and they can start convulsing. That's hypoparathyroid, and the real problem is low calcium. Hyperparathyroidism, I can't say that I've ever seen that. Very rare. The adrenal gland, I consider this probably the most important gland. The way that I remember what part's the outside and what part's the inside is, well, how do I remember this? I can never keep these straight. But the medulla is the outer part. And the cortex is the core, maybe? That'd be a way of remembering that. Let's see if they have a picture here. But every layer of the medulla, the fascinating thing to me, I pulled it up on Wikipedia. I love Wikipedia. I think I've told you this before. It's got a nice picture of the adrenal glands. Notice that it's just sitting there on top of your kidneys. The thing with your adrenal glands is everything about your life today is influenced by this gland. Whether or not you're able to pay attention in class today is all has to do with this adrenal gland. Whether you're happy, whether you're sad, your adrenal gland. Endocrine glands, they produce a ton of hormones. Most important for critical care is adrenaline or epinephrine. But they also kick out the steroids, aldosterone, and cortisol. The outer cortex is divided into maybe medulla middle. Would that be a way of memorizing that? I can't keep that straight. I've never been able to. Medulla middle. The outer layer, the cortex, is divided into 3 layers, and each of those layers kicks out a different medication. A different medication. That's the fascinating thing about that. It kicks out the mineral corticoids, which has to do with the minerals in your body, especially salt. Mineral, think salt. The glucocorticoids, gluco means sugar, glucose. So they regulate your sugar balance. And then the androgens. These are all of your sex hormones, particularly testosterone, which both men and women have. Estrogen, progesterone, testosterone. those three hormones influence your life today. We know that certain mental illnesses, mental disorders, are caused solely by progesterone, the endocrine hormone, and that's implicated in postpartum depression. So that's the outer layer: mineralocorticoids, glucocorticoids, androgens, aldosterone. And then the inner layer are what we call catecholamines. Catecholamines, specifically epinephrine and norepinephrine. So that inner layer, epinephrine, norepinephrine. Both of those two endocrine hormones are also IV medications that we give in the ICU. We give these two meds in the ICU. Our patient who presented to the ER with a blood pressure of 50/20, she was having an adrenal crisis. The very first med the nurse ran in the room carrying is called Levofed, which is norepinephrine. Levofed, or leave them dead, we always say. Epinephrine, we give that for all kinds of critical care problems, including a bee sting. If you're allergic to a bee sting, you might have an EpiPen. That's the middle part of the adrenal gland that secretes catecholamines, epinephrine and norepinephrine. The outer layer secretes glucocorticoids, bring your blood sugar up, your androgens, and your mineralocorticoid. That's super confusing content, and you will see it once every 15 years. But do try to understand it if you can, because we give patients steroids all the time. We give patients steroids all the time. And so you will need to know all about steroids as a medication. And just as you're given a steroid med, think to yourself, this is the adrenal gland. I'm squirting in a steroid into this patient's IV. It's the adrenal gland that's responsible for steroids. Has anybody taken a steroid recently? If you have asthma, you might end up on a steroid to decrease inflammation. Anybody? No?
Right before COVID hit, something wrong with my lungs. They didn't know what it was. It was like month and a half before COVID, so.
Oh man. So here in class, he was saying that he was on steroids for a lung problem. That's probably the most common reason. And it was right before COVID hit. Man, it could have been COVID. I wonder. And in fact, I was looking on the CDC website yesterday, and it is one of the recommendations for COVID still. Certain COVID patients, we want to give them steroids. It didn't help you much. And if you think about like bodybuilders, weightlifters, anabolic steroids, it gives people energy, start gaining weight, which could be good or bad. If you're pumping iron like crazy and you're on steroids, you'll get big muscles. But my brother, when he was a kid, had an eye inflammation deal, and he had to start steroids, and he was maybe 9 years old, and he got super fat real quick. And in the book, you'll read about Cushing's syndrome. And that's basically what we see. My mom too, she has rheumatoid arthritis now. And I didn't see her for almost a year because of the pandemic. And she'd been on prednisone that whole year. and her face just completely ballooned out, gained a lot of weight. Potent anti-inflammatory steroids, we give them all the time. It's that adrenal gland. Think about that adrenal gland.